Mark Delhi, Senior Resident Pediatrics, Kasturba Hospital, Delhi. He is a consultant child specialist running a pediatric clinic in Rohini with courtesy attachment in Jaipur Golden Hospital and Saroj Hospital, Rohini. Running asthma clinic and treating asthma on regular basis. Attended many seminars and CME on allergy and asthma. Also, his additional qualifications are he is the president of IAP North Delhi from 1st of January 2020. He continues to be the president there. He is also a founder member of IAP North Delhi. He is also the secretary of IAP North Delhi between 2017 and 2018. He was the organizing secretary of North Delhi Pediatric Conference held in 2018. Also the convener of NDPC in 2019. He is also a trainer at IAP National, trainer in asthma, IAP zonal trainer in tuberculosis. I would like to welcome Dr. Dinesh Mittal, who is going to speak on antibiotic use in pediatric practice. Welcome, Dr. Dinesh Mittal. Over to you. Thank you.
Thank you, Dr. Mahesh, for the nice introduction. And now I request you that I should be allowed to share the screen for the further proceedings. So today I'll be talking about the antibiotics. So these slides are made by these contributors, and these are the part of the IAP. IAP is the Indian Academy of Pediatrics module on the antibiotics, and it is a big module covering almost 150 slides, but I'll be taking almost half of the module, in which the most important parts will be covered. So friends, we say it as war on microbes, that is, right antibiotic rightly. So if we go into the pre-antibiotic era, the infections were the life-threatening and they were not treatable. They were either treatable by this traditional remedies like haldi and all those things. But after the introduction of antibiotics, the life becomes easy, and after the discovery of penicillin and later other antibiotics, the infection becomes treatable. But what happened after that? We used the antibiotics very irresponsibly, and resistance emerged. The bugs become smarter, and the resistance even spread among them. And then come the era of antimicrobial resistance. So in antimicrobial resistance, among gram-positive and gram-negative bacteria and parasites were there. What that leads to? All the advances we achieved in the past 100 years are being at the verge of nullified. Even today, almost 7 lakh patients die because of the infections, but there is no treatment because there are no antibiotics and the bugs are resistant. And it is estimated that by 2050, it will become almost 1 crore per year. So the problem is really very serious. So now let's see how the bugs get the power of resistance. It is basically a phenomenon of Darwin's theory, that is the natural selection. So if we have a lot of germs, few are the drug resistant germs, if you see in the slide number 1. If we give antibiotics, most of the germs which are susceptible to the antibiotics are killed, while the remaining some few are basically the drug resistant. Now these drug resistance, nobody is going to stop them because they don't have any competition, and because of this they grow and then they spread to the other things. So epidemiological studies have demonstrated that a direct correlation between the antibiotic consumption and the emergence and the dissemination of the resistant bacterial strains. The problem doesn't stop here. The problem is that the new antibiotics are not there, and they are not even in the pipeline. While in 1983, when the resistance problem was not that much, 16 antibiotics were being developed, while in 2008 to 11 only 2 or 3 antibiotics are into the pipelines. Whatever the new antibiotics we are getting, they are just modification of the old antibiotics. But if you can see, there are no new class of the antibiotics as is being even researched. Forget about the availability. So there is a need to for preserving the efficacy and the availability of the antibiotics that are limited by writing antibiotics responsibility. Definitely, their antibiotics still is a very great tool. But if we have gun at home and if we use randomly, definitely it is going to kill us or our kids. But if we use it as responsibility just at the thieves and the looters, then definitely it is a weapon for us. So, what is responsible use of antimicrobials? Antimicrobials are to be prescribed only when it is needed. And what is needed? It should be a right choice. So, what antibiotic I should use in case of, for example, throat infections or gastroenteritis or whatever the disease is there? The choice of the antibiotic should be on a right basis. Then, after you choose a right antibiotic, then it has to be given in the right dose. Right dose means it should not be underdose or overdose. Then it has to be on a right route of administration. So, for example, if a bug can be killed by the oral route, then why to give the IV route or IM route? And then the most important thing again is the right duration. So, for example, if you are diagnosed a tuberculosis and you have chose the right dose and the right anti-tubercular drug also, and you are giving the right route, but for example, if you fail to even explain to them that it has to be taken for a minimum of 6 months or 9 months, whatever the case may be, and the patient stops at the age of after 1 month, then definitely it is going to lead to the antibiotic resistance. So, what are the prevailing practice and the challenges? Now, let us see the case it by the case by case. So Asha's 2-year-old boy is down with the fever, cough, cold for the last 1 day. It is very common scenario for all of us, and it goes to nearby family physician. The family physician prescribed Meftal-P, Cinare-HF, and the co-omoxiclav. I think whatever we say, whatever we do, but most of the people, even today, even after giving so much of knowledge, almost I think almost 60 to 70% or 80% doctors are prescribing antibiotics on a first step. So what is the problem here? Problem is that family physician, which may be allopath or even the non-allopath colleague, they are the first point of contact. So then they may have the lack of proper training, knowledge, or awareness. I don't know about the other part, but in Delhi, even the chemists are giving antibiotics, and in fact, they are giving the first antibiotics and then the painkiller or anything else because they have more profit margin in giving antibiotics. And the family physician, whoever it may be, imitates the pediatrician's prescriptions. So pediatricians are not a holy cow. They are also writing the antibiotics. They may be writing for anything else, but they are influenced. And also, it is an open secret. They are also influenced by the information from the MR, medical representatives, and even some giftings, etc. also. So what about the case 2? Sunny is given amoxicillin and the paracetamol by his mother for sore throat. He was also given amoxicillin for the similar condition, that is a throat infection in the past, and used the leftover tabs from the previous course not completed as prescribed. So if the doctor has prescribed, for example, in 1 month back there was some sore throat or something like that, he prescribed for 7 days or 5 days, but she gave it for 2 days and the child got improved. and she left. After that, the 3-day course is remaining, but in the next month again he's developing the sore throat, and then she started with the amoxicillin. So what is the problems? Problems is failure to distinguish the antibiotics from a non-antibiotic drug. So he was prescribed by paracetamol. So this time it may be possible that the only paracetamol could have been a good drug and amoxicillin may not be needed. I really don't know about what was the case, but it may be possible. Then failure to counsel the parents regarding not using antibiotic next time without prescription. The family physician last time was right in his approach because he might have seen some follicles or some pustules, and he might have prescribed the amoxicillin in the right way, but he failed to prescribe that this medicine is an antibiotic and it should not be repeated. And failure of proper counseling by the doctor to complete the course as the prescription. So, for example, even if the child is improved in within 2 days, then also she has to complete the course of 5 days. The doctor should prescribe this. Now, let us see the case number 3. The case number 3 is the 9-month-old girl has a watery loose stools. Mother goes to the local chemist, and the local chemist gave normetrozole by the chemist. So what is the problem there? Problem is that now the why should the normetrozole or any other antibiotic should be available over the counter? This is the real problem, especially in northern part of India, that any chemist you go and they on the first hand prescribe the antibiotics. Then because the mother has to go to the chemist and not to the doctor, that is again a failure on our part or the government part, because they have poor access to the healthcare facility. The poor access may be because of the cost or maybe because of the availability also. And poverty is there and the ignorance is there. The mother, if the mother is qualified enough, then she must have gone to the doctor. So what is the right way of antibiotic use? Right way is the 4 mantras. That is the right choice of antibiotics, as I already explained it to you. Right dose and the dosing interval of the antibiotics. Right route of administration and right duration of the antibiotics. These are the 4 mantras we should always remember. So we can use the antibiotics in 2 ways. One is the therapeutics and the prophylactic. Therapeutic is when the disease is there and we use it, for example, any urinary tract infection or like something like that. And also prophylactic when there is a suspicion the patient is at a high risk of getting UTI, for example, some congenital abnormalities or something like that. We give in half dose the prophylactic antibiotics. So it is there, it is recommended. So let's go by the therapeutic one. Therapeutic may be another definitive. We know that this is the organism and this is the antibiotic sensitivity, and we are definite that if we give this antibiotic, then the organisms will be killed. The second approach will be the empirical one, where we don't know about the organism, we are just suspecting the organism, and we also don't know about the antibiotic sensitivity also. So we are just presuming that this antibiotic will be sensitive and we are giving it. So let us see. So definitive is the ideal when fraught with the challenges not feasible in every condition. And empirical is the most commonly what we give is resorted to and can be rational and appropriate. So how to practice definitive antibiotic therapy? As I told you earlier, this is the least thing, and we usually don't do in India the definitive therapy, but although it should be done. It requires the microbial diagnosis usually based on the culture with the antibiotic sensitivity testing. So bacterial infection is suspected, then the send appropriate sample properly, start antibiotic empirically, step down and narrow spectrum as per antibiotic sensitivity testing. So now let us see it by case basis. 4-year-old girl, fever moderate to high for the last 6 days. There is no cough, no cold, no loose motion or any other focus. The child has received oral amoxicillin for the 4 days, but she is not better, so admitted. CBC was done, showed the normal WBC count with the neutrophils 70% and the eosinophil 0%. Enteric fever is suspected, so 2 ml of blood was sent for the culture next day. The report, no growth. So what do you say? It is not enteric? It may be enteric, it may not be. Where are the problems are there? Problem is that the sample was sent after the start of antibiotic first. So after 4 days, the child has received the amoxicillin and then the sample was sent. And then it has the most common yield for the salmonella is that when the sample was sent in the first week. In the second week, it may be possible that the yield may not be so much. So it may be enteric, but we missed the chance to diagnose it. So coming to the next case, 7-year-old fever for 3 days up to 101 degree Fahrenheit. The child is cough and sore throat for 3 days, not breathless or toxic. Already started on the amoxicillin. As the child is not better, throat swab was sent for the culture. Culture glows Klebsiella pneumoniae. So now the culture is there. Culture is showing Klebsiella. So what do you think? Is this the Klebsiella the pathogen? I think the interaction is not there, but obviously the Klebsiella is usually not a common pathogen found in the throat. It is usually a blood pathogen. So if the pathogen could have been the streptococcus or H. influenza B or something like that, we would have believed on this report. But in a immunocompetent child, where the immunity is absolutely fine, and we are getting the Klebsiella, then we should have a suspicion. So why the Klebsiella growth may be there? Because the Klebsiella may be a commensal. And as the child was started on the amoxicillin, so whatever the sensitive organisms were removed, and only the resistant Klebsiella, which were commensal, were left, and that was grown into the culture. Now coming to the case 3. Case 3 is the 3-year-old girl, known case of grade 3 vesico-urethral reflex, and is on the nitrofurantoin prophylaxis. She has a history of previous upper UTIs. Coming to the nursing home with a high fever in the late evening, urine sample collected for the routine and the culture before antibiotics started. Sent next morning to the lab, and the lab reported E. coli, that is more than 10 raised to power 5. So diagnosis is E. coli UTI. So was the sample collection was fine? It may be, it may not be, because the child came in the late in the evening, and whenever we collect the sample, it has to be sent to the lab within half an hour. If it is not possible, we should refrigerate the sample between the 4 degrees centigrade at approximately 4 degrees centigrade, so that the other pathogen it doesn't grow. So proper collection of the cultures, either collect sample before starting of the antibiotics, collect sample with due precautions, like in blood or the urine. So in the urine case, it has to be a midstream samples, and in the blood, the proper site preparation should be there. Send sample from the correct site. Tissue fluid aspirates are better than the swabs, because the swabs may dry up, and expedite the transport. This is a very important. After the collection of the sample, it is better to send it to the laboratory as soon as possible and send the adequate amount of the sample. For example, in sometimes the blood culture, we just put 0.5 ml. In the blood culture, it has to be ratio of 1:5 has to be maintained between the medium. Proper precaution for the collection of the blood in the urine sample. If for the blood culture, as the quantity of the blood sent from the culture is increased, the chance of positive culture improves. In children, send at least 4 to 8 ml of the blood in 1 or 2 liquids. In neonates, smaller amount of the blood may still yield positive results. The automatic blood cultures are superior. So backtack and all those methods are much better, and the send correct ratio of the blood to the culture media. So if there is a delay in transport of the lab, then refrigerate sample from the contaminated side, that's the urine and stool. But what about the sterile side, like CSF, blood culture, or the body fluids? They should not be refrigerated, but they can be culture positive is equal to infection. Is it so? If, for example, if some reports comes, we should assume that is a infection. It can be a contaminant organism from the skin of the patient or clinician or the sterile instruments used during the collection or the incubation. And another, as we saw in the last case, it can be a colonizer also. There are thousands of the bacteria which remains as a symbiosis in our on our skin or our in throat or in our lungs also. The organisms present in the non-sterile part of the body, urine, catheter, ET tubes and the venous catheter tubes, etc., but they do not cause infection. And then the third is the true infection. So what is true bacteremia? It depends on the identity of the organisms. Generally, the true infections are E. coli, Klebsiella, Streptococcus pyogenes, Streptococcus pneumoniae, Pseudomonas, Acinetobacter, S. aureus, S. typhi, Bacillus fragilis, and C. albicans. Possible true infection is the Enterococci, which is 78 probability. Viridans group, Streptococcus is the 40 to 60%, and the cones, it is the less. So most of the times, if you get a report of cones, it is usually a contaminant. And the rarely true infection is the Bacillus, Corynebacterium, P. acne, or the Micrococcus. If you get this report, usually just assume it they are the contaminant. So now coming to the case, 14-year-old Rahul, acute onset of pain, redness and swelling in the right thigh after a minor wound which is discharging. The boy appears ill with high fever and the rigors. Diagnosis, abscess and the cellulitis. Pus and the blood culture shows gram stain, gram positive cocci in the clusters. On treatment, clindamycin with the fluoxetine. Is it a right treatment? Let us see. Now, should we change the management? As we send the culture, and the culture report shows this. In this culture report, the penicillin is showing the 3 plus and it is the biggest diameter. And the other things. Is this a right culture report? No. Because so no, so this report is not is not correct. The correct report should be the resistant or the sensitive S or R should be mentioned alongside. So the correct reports with zone size are meaningless. Zone diameter plus 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 or plus plus lead to the erroneous interpretation and have no meaning in themselves. Need to be interpreted and are reported in line with the clinical breakpoints to indicate the possibility of success or failure of antibiotic treatment as sensitive, resistant, or the intermediate. S strains can be treated with the normal dose. This is the interpretation. Very good chance of the success. What if we get the R? Unlikely to respond to the antibiotics, unlikely to achieve a clinical cure. Again, it is a word unlikely. It doesn't mean that the antibiotic will not work. We will see later on, even in the R cases. And what about I? The antibiotic may be used with caution. The possibility of the success, especially with the increased dose, applies to the site with the higher dose, that is the beta lactam can be used, or where the drug are physiologically concentrated at the site of infection. That is the beta lactam and the quinolones in the urine. So this is the right approach, right report. Now, where the penicillin we were assuming to be a sensitive one, it came out to be the resistant one. So even if it is 3 plus, even if the well shows it is a highly sensitive, but the interpretation is the resistant one. We will see why. So in that case, penicillin is out because it is resistant. Now we have to narrow the choice further. Despite in vitro susceptibility, ciprofloxacin and the ceftazidime are not used preferred agent from the Staph aureus. We know from our knowledge that they should not be used for the Staph aureus. Clindamycin sensitivity need to be confirmed by the D test. What is D test? D test basically in clindamycin what happens even if the drug is sensitive, if we give into the body, it develops the resistance very fast. So we do a D test where in the plate of the clindamycin sensitivity, we put a erythromycin also. If it forms like a D, then it is going to be a resistant case. So in that case, if D test is positive, the clindamycin should not be used. Erythromycin is the bacteriostatic, so it is not preferred. So vancomycin and teicoplanin should be reserved. So vancomycin and teicoplanin can be used, but they should be reserved for the MR assay. So what antibiotics we are left with now after this knowledge? So we are left with the oxacillin, cefazolin, and clindamycin. So now after interpreting this report, we are left with the 3 choice of antibiotics. So the drug of choice is the cloxacillin. If unavailable, the patient is allergic to the penicillin, then the cefazolin should be used. Now come to the case 7. 7-year-old girl complained of dysuria and the frequency of urination. Urinalysis show the pyuria and the nitrate positive. Patient empirically given amoxicillin awaiting culture report. Culture grows there is the E. coli. It is resistant to the amoxicillin and the ceftriaxone. But it is sensitive to the cefuroxime, cefixime, ciprofloxacin and nitrofurantoin. But clinically, the patient has improved on the amoxicillin. So what happens? Is the report is not correct? Why DST is showing that it is a negative, it is a resistant, but why the patient is improving? Is my diagnosis wrong? No, nothing like that. Because the answer lies about the tissue concentration. Whatever the antibiotic sensitivity is given to us is at the serum level. But some antibiotics are highly concentrated at the tissue level. For example, in case of amoxicillin, the bladder concentration of amoxicillin is the 600 microgram, but MIC is 32 microgram. That is why they have reported it to be resistant at the 32 microgram, but it became effective at the 600 microgram. That is why the amoxicillin worked in this case, though even after showing the resistance in the antibiotic sensitivity test. So what are the take-home messages in interpreting DST reports? DST reports should be available as sensitive, intermediate, or resistant. SIR reports are based on the projected serum level. This is very important, and they may not correlate with the tissue level of antibiotics. The clinical judgment is required in choosing antibiotic instead of blindly following the DST report, as in vivo susceptibility may not be same as that of in vitro sensitivity. So what if culture are not possible, are not available? That is the most important thing in our settings. So known culture method of the bacteriological identification may be applied. So what are the known bacterial culture method? Microorganisms of the microscopic organisms, the like pus, the pleural drains, the CSF and the AFB. then we can do the antigenic testing, like in pneumococcal antigen in the urine, the rapid streptococcus test, or the CSF detects agglutination. Then, as we commonly do in typhoid fever, the typhoid test is done by the antibody detection, the mycoplasma recticid infection, or the streptococcus infection. That is, we do in the ASLO titer we see, and the PCR, that is the bacterial DNA identification, as we are routinely doing now in case of COVID. So, but can we know the organism without the drug sensitivity? How is it useful? Even if we detected that there is a salmonella on the basis of typhoid test, but we really don't know the sensitivity of this organism. So, which antibiotic we have to use is again becomes a difficult. So, it is always better to go for the culture test. So, choice of antibiotic as per pathogen respiratory pathogens. So if we see the respiratory pathogen, the streptococcal pneumonia, the first choice should always be the penicillin G or the amoxicillin, and the alternative may be the cephalosporins or the macrolides. Staph aureus is the fluoxetine or cefazolin. Clindamycin, linezolid, and the vancomycin are the alternative. Hib is the amoxicillin. Mycoplasma is the macrolides. How do you choose the empiric antibiotic? Definitely, therapy is always not possible, as we all know. Test of detection of the organism has been sent, but the results are awaited. Yeah, this may be a possibility. Another, why the definitive therapy not be possible, organism cannot be assessed for the culture. For example, if there is patch in the lungs, we obviously cannot get the organisms, or the otitis media is there. Certain organisms cannot be cultured in the laboratory. The fastidious or the slow growers. For example, if we want to go for a culture for tuberculosis, it is very difficult. It takes months. Or maybe case of rickettsia or mycoplasma, it is very difficult to culture them, and how to find a facility for the culture are not available or affordable. As in most of our cases, they are again a major problem in India, and culture are hindered by the prior antibiotic therapy. This is again a major problem in India, that wherever we get a patient, most of the times they get the antibiotics on their own before coming to us. Now see the case number 1. 4-year-old girl writes submandibular swelling and the acute suppurative lymphadenopathy. Should we use the empiric antibiotic? Yes, we have to use empiric antibiotic because the child is toxic and the pathology is in front of us. So 2-year-old boy, he's toxic, high fever, 2 days, blood and mucus in the stool, 1 day, and the diagnosis is the bacillary dysentery. Again, should we use the antibiotic? Yes, because we know that the most probable organism may be the either E. coli or Shigella or something like that. Yes, bacterial infection are the obvious clinically, so we should start with the empiric antibiotic. Now let us see the case number 2. 2.5-year-old boy, fever with a cough 3 days, breathlessness 1 day, febrile, sick, crepitations present, and the clinically the child is pneumonia. Would you start an antibiotic? Yes. In this case, again, the child is 2.5 years and he is breathless. So he is a sick child. So we should start the antibiotic. Let us see another case. 5-year-old boy, fever since 5 days, history of poor appetite, sick, look toxic, coated tongue, soft torpedo, splenomegaly. Another, yes. High probability of bacterial infection, send investigation before starting antibiotic, repeat antibiotic trial not justified. And for example, if you have started the antibiotic, it's not working, and then again, even if you have not sent the culture report, and then you again repeat the antibiotic with any another antibiotic, it is definitely not acceptable at all. So case 3 is a 2-year-old boy with a fever, 2 days, crying on passing of the urine 1 day, urine analysis 15 per cell per half field. Should we start the antibiotic? Yes. Clinical diagnosis is collaborated by the lab investigation, but attempt microbial diagnosis, send the urine culture before starting of the antibiotic. Case number 4, 16-month girl, high fever, coryza and cough, maculopapular measles-like rash, starting on day 3 from behind the ears and spreading centrifugally over 2 days. Afebrile for the day 7. Develop fever again on the day 8, cough, breathlessness, crepitation, the chest auscultation. Should we start antibiotic? Yes. Viral infection with the atypical progression with the suspected suprahead bacterial infection is there in this case. So the case is of measles, and the measles after the measles the suprahead bacterial infection is there. So we have to start the antibiotics. So empiric antibiotic in these cases. Bacterial infection is obviously clinical. We should start antibiotic. High probability of bacterial infection on the clinical grounds. High probability of the bacterial infection on the clinical ground plus suggestive lab investigations. Viral infection with the atypical progress. So now let's see the case A. A neonate is brought with the refusal to feed for the few hours. History of fever 1 day prior. On examination, hypothermic and the limb. The child is really a sick child. Would you start an antibiotic? Of course, yes. The child is critically ill and we cannot wait for the culture report. 2-year-old boy under treatment for all. ALL, sorry, acute lymphoblastic lymphoma. HB is 8, TLC is 1080, and neutrophil is 20. The absolute neutrophilic count is just 204. So he's also complaining of anorexia and the fever for 1 day. Will you start antibiotic? Yes. Extraordinarily susceptible, because in this case the child is immunocompromised and the ANC is less than 500. So the body is not able to even fight the infection. We have to assist the body. So in this case, the waiting is risky. Empiric antibiotic only if high probability of bacterial infection only when the waiting is dangerous, life-threatening infection is suspected, or immunocompromised patient, as we have seen in our previous cases. Presumptive empiric antibiotic use. Bacterial infection is suspected, but it is not proven. Start antibiotic, attempt to prove and identify the organism. Infection is proven, change to appropriate antibiotic. Infection is not proven, discontinue. Don't shy away from the discontinuation of the antibiotic if you fail to prove the infection. Choosing the right empiric antibiotic. So before choosing the right empiric antibiotic, we should keep some things in our mind. So we should always think about which pathogen we are dealing with. What is the site of infection, the severity of the illness, host comorbidities, and the suspected drug resistance. To this single agent, as far as it is usually seen that many times one patient is getting 2 antibiotics or 3 antibiotics, but we should choose single agent as far as possible. Only in certain limitations we have to give the combined or the multi-drug therapy, multi-drug regime. How empiric antibiotic choice is made? Now let us see. 2-year-old non-severe acute otitis media proposed to be treated with the amoxicillin. Now I have made a that thought in my mind that the acute otitis media is there and we have to treat with the amoxicillin. So what is the causative organism? Causative organisms of the acute otitis media may be the virus, the streptococcus pneumonia may be 35% cases, H. influenzae 21, Moxella catarrhalis 12%, the others are the 2%. So sensitivity is virus, obviously there is no antibiotic sensitivity, so 30% will be there. Streptococcus pneumonia, if we treat it with amoxicillin, then the 95% will be treated. So 33% will be the cured one out of this 35%. H. influenzae has the sensitivity of 60%. So 13% again will be treated by just using the amoxicillin. 40% of the Moxella catarrhalis is sensitive to the amoxicillin and the 5% is treated, and the 50% are others are sensitive to the amoxicillin, so 1% again here is treated. So just with the empiric therapy, if I have made a diagnosis of streptococcus pneumonia, and amoxicillin will be successful in almost 82% of the cases, very high chance of treating it. Do you have to go through the exercise each time for the infections? No, because we have certain guidelines. IAP has the guidelines, and we have a course of RTI GEMS and the IAP guidelines for the malaria also. Even the national guidelines are there for treatment of the infections, and they'll be available very soon. So empiric antibiotics when there is a highly probable bacterial infection, clinically certain bacteria, atypical progression of the viral disease. So we should choose the empiric antibiotic. So clinical pneumonia urgency is there, life-threatening infections of the ICM host. So likely pathogen, we have to find the likely pathogen, site of infection, host comorbidities, severity, and the drug resistance. So choose a single agent as far as possible. So what are the common errors in the antibiotic therapy? In this section, we'll look where we go wrong in the antibiotic therapy and thereby not only fail to cure but can contribute to the worsening of the AMR. Now let us see the case number 1. We will do just 15 more slides, I think 15 more minutes, 10 more minutes, and then we'll wind up. 2-year-old asymptomatic child contact with the tuberculosis, put on the INH prophylaxis, develops fever, cough, weight loss, goes to the second pediatrician who adds rifampicin. So I will say that both the pediatrician have made a mistake, and the child is not better. After 6 weeks, the CT shows the massive lymphadenopathy, gastric liver shows the mycobacterium tuberculosis, and they are all resistant to the first line drug. So where the mistakes has been done. So in the first case, the first pediatrician just gave the monotherapy, and even he didn't care to diagnose whether the child has developed the disease or not. So he thought he's giving as a prophylaxis. That too was not a correct one. He should have diagnosed whether the child has progressed to the disease, and even in the second pediatrician should have added SRZE rather than just adding the rifampicin. So both the pediatrician created a mistakes and then led to the multi-drug resistant tuberculosis. In case 2, 18-month-old child with a fever, irritability, red and bulging eardrum. Diagnosis is the acute otitis media. The child is put on the amoxiclav now in the correct doses. There is no mistake by the doctor, but the parents reduced the dose to half, and the child developed diarrhea with the full dose. वेरी कॉमन अक्रेंस डॉक्टर साहब इससे तो 10 लग जाते हैं, मैंने आधी डोज दे दी, या एक ही आपने सुबह शाम लिखी थी, मैंने तो एक ही बार कर दी. 4 days later, still running fever, throws a conversion, the CSF grows the beta lactamase producing H influenza B. So the error is inadequate dosing by the parents. So case number 3, preterm lethargy, seizures on the day 4, CSF suggestive of meningitis. The child is started on the cefotaxime or the amikacin. Improve, look fine for the 9 days. Send home on the oral antibiotics as parents do not want to stay in the hospital. So this is a case of neonatal meningitis, and we all know that it has to be treated at least for 21 days in the hospital with the IV antibiotics. So in this case, the mother came back a month later with the brain abscess due to the ESBL producing E. coli. So error is the duration. Giving antibiotic too short for a time is again a error. So what is the error in the last 3 cases? Inadequate number of antibiotic, inadequate dosing, or inadequate length of the time. In all these cases, incorrect use of the antibiotic led to the worsening of the clinical condition and led to the development of the antibiotic resistance. So the principle of choosing an antibiotic, select the drug with the narrowest spectrum effective for the pathogen, likely to be less toxic, will reduce damage to the resistant flora, less danger of inducing drug resistance in the patient and the environmental flora, to save higher broad spectrum drug for the future use, and the use single agent as far as possible. So let us discuss just certain practice points. 5-year-old girl with a progressive fever, severe anorexia and occasional vomiting, soft hepatomegaly. lean omega 3. CBC is 12.5 HB, WBC 6200, H 68, platelet 2.2 lakh. Blood culture is same. The child is started on the ceftriaxone. So STFE on the culture sensitive to the ceftriaxone now and azithromycin and the resistant to the quinolones. Azithromycin is added. Is this a right approach? No, it is not a right approach because we don't want a multi-drug thing. Even if the ceftriaxone was started and it is sensitive to the ceftriaxone, definitely it would have worked. There was no need for the azithromycin to be added because it will lead to again the resistance. Combination of two or more antibiotics when the serious or bacterial infection is there as the unknown pathogen, presumptive therapy. Empirical therapy is seriously ill hospitalized patient. The child is very sick, then we can definitely think about the adding two drug, but it should not be used as a routine. Where the mixed infection is there, where we, for example, road traffic accident with the open contaminated wound. So it may have, the child may have the aerobic, anaerobic, and the bacteria also. So, there we can add the multiple antibiotics to delay development of resistance. For example, in case of tuberculosis, we routinely add the multiple drug. In fact, we should not use the monotherapy at all. Similarly, in case of HIV and the falciparum malaria is there. And only in the exceptional cases where the true synergy is there, that is the penicillin and the aminoglycoside in the Streptococcus viridans in the bacterial endocarditis. Again, a very serious condition, bacterial endocarditis, and the true synergy with the penicillin and the aminoglycoside. So choosing your antibiotic, what other factors to be considered? So which antibiotic, what are the host factor, and what are the organism? The combination of this has to be seen to consider the. So let us see the host factor. There will be different antibiotics in the immunocompetent and the immunocompromised. If there is any drug allergies, obviously if the child is having a penicillin drug allergy, then we should not use the penicillin, but in fact use the macrolide kind of. If the child is liver dysfunction, some antibiotics which are secreted by the liver, if they are there and the liver dysfunction is there, we cannot use those antibiotics. Similarly with the renal dysfunction and the other current medications. So now let us see the case. 9-month-old infant weighs 4.3 kg, brought with the fever and the loose motion. This some dehydration. This is a case of nutritionally derived acquired immunodeficiency or the severe acute malnutrition. The child is malnourished, as you see, 9-month-old and the 4.3 kg. Should you use antibiotics? Generally, we say that we should not use the antibiotics in the loose dose, but yes, in this case, we have to use the antibiotics because the child is immunocompromised child. He is not an immunocompetent child. So what are the acquired immunodeficiency? If the child is using the steroids, more than 2 mg per kg, more than 2 weeks, 20 mg per day, T and B cell suppression. So pathogen, it causes S pneumonia, MTB, listeria, nocardia viruses. So third generation cephalosporins can be used for ABM cover for the listeria with the ampicillin. Add antifungal in case of nosocomial infection. Consider PCP in setting of the pneumonia with the diffuse. Similarly, burns. If a child is burn is coming, that the staphylococcus or the pseudomonas and the other gram negative is there. Anti-pseudomonal BL anti-staph should be used. Malnutrition, usual pathogen, increased risk of staph aureus and the gram negative. So ceftriaxone or cefotaxime can be used. HIV, TB, PCV, cryptosporidium, cryptococcus, non-salmonella, toxoplasma can be. So depending on the site of infection, suspected pathogen and severity of HIV. So in children, we see even the primary immunodeficiencies also. That was the acquired immunodeficiency. In this, the P-cell defect is there, the capsulated organism, staph pneumonia, HIV, they are more suspicion, the third generation cephalosporins. Granulocyte defect, and then I think we should skip this slide because this is too specialized and usually it is not catered. So now coming to the drug allergy. 4-year-old diagnosed with a pneumonia on the oral amoxicillin develops itchy maculopapular rash, angioedema and hypotension during hospitalization. The child is diagnosed with the drug allergy to the amoxicillin. So change to the ceftriaxone. So ceftriaxone is again a penicillin group, but should we be concerned? No, we should not be concerned because most of the cases when after second or third generation cephalosporins, they are not sensitive. The drug sensitivity is not there, even if they are allergic to the penicillin. Although in severe cases it should be avoided. G6PD deficiency, 2-year-old boy with a history of UTI was put on nitrofurantoin, was brought to 2-year-old history of fever, passing of the red colored urine. On examination, pale, other symptoms are normal, HB is 6%, urine occurred blood positive, DCT negative, G6PD level very low. So it is a diagnosis of non-hemolytic anemia in the G6PD. So if it is a case of girl, definitely this should not have been occurred. So we should be careful while giving these drugs like antimalarials, nitrofurantoins, sulfur good drugs before giving to the boys. So adherence is difficult to assess, but important must be make an effort. So how to make the children adhere to the dosing? So less frequent dosing, for example, if we are giving just once in a day dosing, it is likely to be more adherent. Shorter course are definitely better than the longer course. Tablet versus syrup. Some children prefer tablets, some children prefer syrups. They may have different taste and the flavors, so we should keep all these in mind. What I do in my practice is that I usually, whenever some medical rep comes, I just taste the medicine. If it is bitter to me, and if I don't like, I just don't prescribe. So that makes it more adherent. Relate dosing to the daily events. For example, you can relate it to the, you can have this antibiotic after the breakfast or the lunch or dinner. So it is there. It is always better to keep a record. So after taking the medicine, the child or the caregiver can tick. So it can, or otherwise you can count the remaining medicines. So that can again be a useful therapy. And the direct observation, that is what we follow in the DOTS. So what is the ideal antibiotic? Ideal antibiotic obviously is not there. We don't have any ideal antibiotic, but it should harm the bacteria, but not to us. It has a narrow spectrum, minimal adverse effect, various route of administration, IV, IM or oral, good distribution to the site of infection, has high threshold for developing resistance and the inexpensive. However, all antibiotics are toxic to the some degree. So for this, I think we should conclude a session because it is again a long session. It is almost 1 hour, and we are now open to the question and answers.
Thank you, Dr. Mittal, for that lovely talk on and highlighting the use, misuse, abuse of antibiotics. Now, coming to a few questions, we have the first question from Dr. Alok Nigam of role of antibiotics in daily use.
Pardon, sir, your voice is breaking.
What are your comments about this?
Can you repeat the question? Your voice was breaking.
Dr. Alok Nigam from, yeah, Dr. Alok Nigam from Lucknow has asked, what is the role of antibiotics? Am I clear?
So voice is breaking.
Again, repeat the question again, Mahesh.
Am I audible now?
No,
yeah.
Am I audible now?
Yes.
Yes, sir.
Yeah. Dr. Alok Nigam from Lucknow has asked, what is the role of antibiotics in daily use?
Role in daily use?
Yeah.
Of course, the antibiotic has to be used judiciously, and if we do not have any infection, of course, in daily use we cannot go for infections. I think dairy use or daily use? DAIRY, dairy.
He has asked daily use. No,
It's a
no,
big
no.
question.
DAILY.
I can't get it.
Question is vague, sir.
Maybe he's trying to ask. Maybe he's trying to ask which antibiotic can be freely used. You know, a lot of today's generation, they go in for higher
So
antibiotics
basically,
at the drop of
what
a
is the
hat.
funda is, what is the common practice is that first of all, whenever there is a cough and cold, most likely it will be a viral disease. So do not
Exactly.
use antibiotics. तो पानी जैसा कहीं से भी आ रहा है तो वो बैक्टीरिया नहीं होता, चाहे वो पानी जैसा दस्त है, चाहे पानी जैसे जुकाम है, और अगर खांसी है तो वो बैक्टीरिया नहीं होगा, तो वहां पे एंटीबायोटिक यूज नहीं करनी है। सेकेंड चीज है जहां पे मल्टीपल सिस्टम एक साथ इन्वॉल्व होता है। For example,
Okay.
I have fever, I have cough, I have cold, I have loose motions also. 99.9% it will be a viral thing. So don't be afraid and never use, I don't use antibiotics in those cases. Third thing is that most of the bacterial infection में जो fever आएगा, it will be a gradual onset most of the times. If you see typhoid fever, in the first day it will be just 99 or 100 fever, the second day it will be 101, 102, 103. Then if it is there, then definitely we should suspect the bacterial infection. But if the on the first day onset the fever is high grade and slowly on day 2 or day 3 or day 4 the fever is going down in terms of frequency as well as the amplitude. For example, in the first day 103 fever आ रहा था और every 4 hourly आ रहा था. On the second day or third day, it is coming like 102. Now it has gone down and it is now shifted to the every 6 hourly or 8 hourly. That means it is a viral infection. So first of all, we have to differentiate between the viral infection and the bacterial infection. And of course, antibiotics is the antibiotics. That means it is an antibacterial, not antiviral. So we never have to use the in the antiviral. If we choose to go for the antibiotics and we have identified the bacteria, then always remember above the diaphragm, if we see above the diaphragm, usually we encounter with the gram positive organisms. So better to use the penicillin groups of antibiotics. Below the diaphragm, better to use the third generation antibiotics or ciprofloxacin, whatever the thing. For example, in case of UTI or the bacillus dysentery, you better use the cefixime or azithromycin or something like that. But if in case of pharyngitis, bacterial pharyngitis, better to use the penicillin groups of the antibiotics like amoxicillin or amoxiclav or something like that.
Excellent. Yeah. Okay. Now the next question is from Dr. Krishna Rudra Batala from Vishakhapatnam. His question is role of probiotics in childhood diarrhea. Also, there is a similar question from Dr. H.V. Sudhamani from Bangalore. Role of pre and probiotics along with antibiotics. Your comments, please.
Yeah. First of all, probiotics in case of diarrhea. Uh, as per studies, it's shown that the only two probiotics are effective in case of diarrhea. One is the Saccharomyces boulardii, and another is your Lactobacillus GG, Lactobacillus rhamnosus GG, LGR, जो अभी आ रहे. The other probiotics are usually more of a cocktail preparations, like multiple brands are coming, multiple with multiple things, and the other probiotics are usually not very effective. But mind you, all these probiotics are very, very costly. It has been seen that even after using of Saccharomyces boulardii, which one sachet cost almost 50 rupees, and if we go with a 5-day treatment, it costs almost 500 rupees. The duration of diarrhea just gets better with the just 1 day. So if the patient is affording, so you can use the probiotics in case of viral diarrhea, but better if the patient is not very, very affording. So it is better not to use because anyways the diarrhea will improve on its own. It may take one more day. As far as the use of probiotics in case of antibiotic resistant antibiotic uses, again the studies shows that the most of the even probiotics are susceptible to the antibiotics. So if you are using the antibiotics with probiotics, you are again killing the probiotics. Your antibiotics will even kill the probiotics. So most of the time it won't be used. But in certain cases with the antibiotic associated diarrhea, this may be useful. But again, the strains is very important. The Saccharomyces boulardii is again a important this in the antibiotic induced diarrheas.
Okay, we have an interesting question from Dr. Chandramohan from Kollam. He says, regarding you spoke about a lot of culture and sensitivity reports. He says reports with minimal zone plus actual inhibition zone plus sensitivity pattern is the ideal one as we can find the most effective antibiotic. Your comments on this?
Pardon, sir? Can you repeat the question?
He says in culture and sensitivity reports, reports with minimal zone plus actual inhibition zone plus sensitivity pattern is the ideal one as we can find the most effective
No, sir.
antibiotic.
Sir, basically, the thing is that the zone is never a resistant or sensitive thing. Zone doesn't imply, it just imply about the concentration. Actually, what happens in a plate where the bacteria is grown, we just use the drug filter papers. We just put the drug filter paper and then the clearing is there. That clearing is just depend on the concentration of the drug is being used and the way it spreads.
Yes.
Basically, if you use the larger concentration of the drug, it never means that the drug is killing that organism to the larger degree. So the zone size doesn't matter. Only the matter is the R, S or I pattern.
Okay.
You should always look for the RSI pattern and your other knowledge you should use. For example, I have already given in the example that in the Staph aureus, the certain antibiotics are usually not sensitive, so we should not use those things.
Next question is from Dr. Shivesh Gupta from Mumbai. Very apt question for today's atmosphere. He says, due to COVID-19, azithromycin use has become rampant. I agree to this. Do you think we should reduce use of azithromycin now? What is your opinion?
So earlier I also used to use the azithromycin because COVID was a new disease and we really don't know what the weapons we have. And I earlier used to use the hydroxychloroquine also, but now I have absolutely stopped it. So azithromycin, hydroxychloroquine do not have any role in COVID as per WHO and even in my practice. So we should not use the antibiotics in COVID also. Another thing is that what I want to just add is that whatever the gut flora is there, we have the very healthy gut flora. Most of the time, it acts as our immune barriers. So if we are taking the antibiotics, you are reducing your immunity, not you are increasing your immunity. So for example, in cases of some viral diseases, the COVID is again a viral disease. You just want to help your body, but you are killing your own immune cells, which is in the form of the natural gut flora. So we should avoid using the azithromycin or any other antibiotic.
Any antibiotic, the coliforms. You are destroying the coliform bacteria in the gut. Yeah. Okay. There's one more question from Dr. R.M. Arora in Indore. He says, does inappropriate antibiotic use can be life-threatening or can lead to septicemia?
Pardon, sir?
Does inappropriate antibiotic use, can it be life-threatening or can it lead to septicemia?
Of course, it can be life-threatening if it is allergic to allergy cases. Another case, it can lead to the septicemia. It may or it may not be, because if it leads to the antibiotic resistance, definitely
yes.
the septicemia will be there.
Yeah.
But I don't know it can lead to the direct antibiotic use.
Maybe some other class of bacteria can attack the immunocompromised person.
Yeah, of course.
Yeah, because you've already developed resistance. Yeah. The next question is from Dr. Shivesh Gupta from Mumbai. He says, in pediatric practice, which is the best class of antibiotics to start for upper respiratory tract infections? Is it macrolides or penicillin?
I already told you that in the respiratory tract, which is above the diaphragm, we always prefer the penicillin group. So amoxicillin, just plain amoxicillin will be our first line of antibiotics in most of the cases.
Dr. H.V. Sudhamani from Bangalore has asked when we can use antibiotics in children under the age of 1 year. I really don't know what it means.
We can use the antibiotics even in case of newborn. In fact, we are using the
Yes,
antibiotics,
yes,
lot of antibiotics even in the nurseries, newborn nurseries also. So
yes.
age is definitely not a criteria to use the antibiotics or not use to only the indication. If it
Indication,
is
yes.
required, we have to use it. We should use it. But if we don't require, whatever the age is, we should not use it.
Yeah, and with a high degree of suspicion also.
Yeah.
Yes. Yeah, that's all for now. I think that's all we are with the questions. Thank you so much for answering all the questions. Now I would like to hand over the mic to Dr. Pragnesh, who's waiting, a good friend of mine. Thank you, sir.
Thank you, Dr. Mahesh. Thank you, Dr. Mittal, for it was a very nice interacting session, and I can see the interest by the flurry of questions that you had after completing the session. It is always a tricky decision to get influenced by the patient's relatives, because whenever the child uh, felt sick, the problem is everybody is in the fast gear to make things work fast. So there is always a pressure on the doctor to write antibiotic from day one. So anyway, you have covered.
Sir, if you allow me, can I share my experience?
Yes, sir. Please go ahead.
So it is about the use of antibiotics. From the initial start, I was very much against the use of antibiotics, and it was almost around 10 years back when a child has visited to almost all the pediatrician of nearby area, and every time the child gets sick, he gets fever for 2, 3, 4 days, and within few days the fever shot up. Again, it became initially it was 100, and within 2 or 3 days, it came out to be like 102 or 103. Then I went for the investigations, and at that time, the child was detected with the UTI. Earlier, then I treated the UTI properly for 10 days treatment, and the child never had this kind of problem of frequent fever.
Right.
The reason was that every time the child was going to a pediatrician, they were prescribing the antibiotics, and because of the repeated antibiotics, there was nothing was coming into the investigations of the culture, and they were
Right.
missing things.
Right.
So if we see that we are fearful of losing patient, I am 100% sure that if you stop using the antibiotics and if you start using the judicious antibiotics, you'll be gaining a lot more patients than you are losing.
Absolutely. I agree on this. Thank you very much, sir, Dr. Mittal, sir, for sparing your valuable time and joining us today for this FAPI webinar and enlightening our members about this. And thank you, Dr. Mahesh, for nicely conducting this session. Thank you, everyone. Bye.
Thank
Thank
you.
you.
Bye.
Bye.
Bye. Good day.
Thank you, sir. Thank you,
Thank
Dr.
you.
Dinesh, Dr. Mahesh, Dr. Pragnesh, to all.
Thank you, sir.
Thank you,
Thank you.
Dr. Bajpai.
Nice.
Thank you.
Nice session. Nicely explained, sir.
Thank you, sir. Thank you.
Yes. Nice. Mahesh.
Thank you.
Dinesh, are we offline?
Thank you, Dr.
Nice job.
Bajpai,
Nice
for
job.
giving.
Yes.
Yeah, thank you, Dr. Bajpai, for giving me
Yes.
an opportunity.
Dinesh, are we offline?
We'll
Nice,
catch up
nice.
sometime. Yeah, thank you.
With us? Speaking.